All right. Good morning. I'm Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control and Infectious Disease Physician for the University of Kansas Health System. Dr. Stites is off today. He is well. He just has some other clinical duties. We are coming to you from the Dolph Simons Family Broadcast Studio. And today we are doing Follow-Up Friday, and here to help answer any of your COVID and vaccine questions about kiddos. And we have a special guest, Dr. Barbara Pahud, who is the Research Director of Pediatrics and Infectious Diseases at Children's Mercy and is a Clinical Associate Professor of Pediatrics at KU School of Medicine as well. We will get to community questions soon, but first, just some of today's numbers, which I will still be giving. Today, we are still doing fairly well in general. We have 10 acute infections in the hospital, with 5 of those in the ICU and 3 on the ventilator. We still have 8 in that recovery period, so 18 total patients. We've really been holding on to that 20 to 30 range. Right now, going into the weekend, we have just under 20, so that's a good deal as well. Hays has been really at a plateau. They have 3 active infections and 1 in that recovery period as well. But before we jump to any of the community questions, just wondering if there's any media questions.
We're good.
All right. Well, good. So we have Dr. Pahud here. And Dr. Pahud, we get a lot of questions about vaccine trials for pediatrics. Can you update us on the trial underway at Children's Mercy?
Sure. So we just started this clinical trial about, I think, 2 weeks ago now. And this is what we call a phase 1 clinical trial. So what that means is whenever you have a vaccine released into the public, like the Pfizer or the Moderna vaccine that we're currently using, the first thing you need to do is find the right dose. How much vaccine are we actually going to be giving you? So now that we have the answer for adults, and for example, with Pfizer, we're doing 30 micrograms. So now that we know that, we need to figure out how much of that vaccine should we give to the kids, the exact same dose or a smaller dose, right? We don't know if 30 might be good enough for you. Should we give it to a baby this big, or should we cut it into a much smaller piece? So the dose finding studies, or the phase 1 that we're currently doing, basically means we grab the dose for adults and we give a percentage of that, maybe 10% to the babies, and we see how they do. If they do well, then we go up on the dose and we see how they do until we reach a point where they start having side effects that we may not tolerate as parents. For example, if they develop a high fever or if they're not feeling too well. Then we stop and we see if the vaccine is creating a robust immune response, and that's how we try to find that dose that is immunogenic, but also does not have side effects that would stop you from giving it to the children.
Yeah, and we should note that dose-finding studies, just as you said, phase 1 studies, are common, and that was done in the adults as well. Are you still enrolling children, and what is the criteria for getting your child in one of those studies?
So for the phase 1 studies, we are still enrolling right now. We are very close to finding the dose for children, so that's good news for everybody. Because the moment that the few centers that are doing this research study, it's about 6 of us across the world, find the dose for pediatrics, then that dose gets basically locked in, and then we move on to the major clinical trials that you've seen in the news everywhere around the world. So this is exciting. Once we find the dose, we can start enrolling more children even in the trial that we will be doing at Children's Mercy and potentially here at KU as well.
And just in general, for other vaccines, adults and pediatrics, say influenza vaccine, what are those dose variations? Are there any?
Yeah, so there are variations in what we do. For example, the varicella vaccine that we give to children is a much smaller dose than the zoster vaccine that we give to adults. It may be news for some people that are watching right now, but actually varicella and zoster are the same thing. It's actually the same virus. But the vaccine that we give to children is a smaller percentage of the zoster vaccine that the adults get, but it has the same impact to protect you from getting varicella. And once you get varicella, when you're an adult, you will have it again as zoster or shingles.
And how about influenza vaccine?
Influenza vaccines, we've also had smaller doses be given to babies, and so we are trying to make sure that we find the right dose also for the COVID vaccine, so that we're not giving maybe the same dose that you got. I don't know how the rest of you guys here felt after the vaccine, but imagine that in a 6-month-old baby. We want to make sure that parents feel comfortable giving the vaccine.
Well, we'll be looking forward to that data for sure. So do you have any idea exactly when something, the EUA, just pivoting a little bit, the EUA for the vaccine may be extended to children, pediatrics?
Yes, I do have an idea.
Okay.
So the Pfizer product, again, is leading the way with other manufacturers, and everybody's following closely behind. Pfizer has already finished the acquiring the data that they need to submit for the FDA. So they've already submitted it, but as you know, there's been a lot of things going on in the news with the blood clotting adverse events following the adenovirus vector vaccine. So the FDA is busy reviewing that data, trying to figure out if they can get the Johnson & Johnson vaccine back on the market, and that put the approval of the pediatric vaccine on the back burner. As soon as they clear that out, they're going to be able to review the data, and if the data looks good, we're going to be able to bring a vaccine for children approved for ages 12 and above. And then the studies that we are currently doing go from 6 months to 11, so you're going to have to wait until we do that study because we haven't even started the major clinical trial.
Well, we'll be looking forward to that. And just to say, in general, the amount of dose and the amount of material that you're receiving in the current Pfizer and Moderna vaccines are extremely small doses in general. So just pivoting a little bit, we know that in general adults don't like needles and don't like getting shots. We know that you have a comfort promise for children and needle sticks. Kind of, can you tell us, walk us through that for a little bit?
Absolutely. So at Children's Mercy, we are trying to make uncomfortable situations as comfortable as we can. So that means we are going to be giving numbing agents to the children before they get their blood draws, and that may help, but of course you have to remember that little ones will be upset when you walk into the room and just put something to tie up their arm and may cry, not because they're hurting, but because they're afraid. But what we're trying to do is numb the area so that they don't feel the pain of the needle as you're drawing the blood, or use a Buzzy Bee, for example, when we're giving them an injection, so that it's a little bit more comfortable to participate in these studies.
Yeah, I mean, it is scary, and just anecdotally, you know, I have been a significant proponent of vaccines for my children since they were born, and so now it's just a matter of fact, and they've gotten used to that. And it's just a little bit of pain for sure, but I think that's one other way to go about it. So, Jill, we should get to our community questions.
We have a lot of them. We have a few this morning before we go to the graphic questions.
Okay.
Pam says that she has a good friend who's refusing to be vaccinated because she says the EUA designation means this is experimental, and so it's not safe. What would your response be to that, and how would you sway her?
So she is partly right in that emergency use authorization literally has that in the words. This is approved for an emergency. And if you all have paid attention in the past year, we're in the middle of a pandemic, so this is what we would consider an emergency. So the reason why we do this is if we do clinical trials in 30, 40,000 participants, and we notice that that vaccine is safe in 30 to 40 participants, and that it could potentially be life-saving, we don't want to wait 2 years for that clinical trial to finish to make that vaccine available to the public. Because I wonder if you would like to wait 2 years to get your vaccine before you go back out there to complete data on 30 or 40,000 people, right? So what that means is it's a warning. This study is not done yet, but we have this potentially life-saving medication on our shelf that has been reviewed, and we deem it to be safe enough to be released to the public with that warning. Do you want it? And then if people want it, they can take it. That's exactly what an EUA means. Now, there's a flip side to that I want to make sure I explain, if that's all right. When you do clinical trials in 30, 40,000 people, you can only find risks that are 30 to 40,000 people big, right? If you have an adverse event like in Pfizer, and you have a side effect that is 1 in a million, such as anaphylaxis, or Moderna, we saw it, right? As soon as the vaccine started to roll out in the public, we started noticing that there would be about 1 in a million cases of anaphylaxis. So you can't find that in the clinical trial with 30 to 40,000 people. You have to wait until you release it into the public to find that. So if we had waited 2 years, let's say it was a perfect world, we waited 2 years, we finished the clinical trials, and then we released it, the same thing would have happened. As the vaccine gets rolled out into the public, we would have been able to find these cases of anaphylaxis because the clinical trial was limited to 30 to 40,000 people versus once you roll it out, you start noticing very rare side effects. And then you make decisions about whether it's worth it to continue to vaccinate or not.
Yeah, it's all about benefit versus risk. And I would continue to say that really do your due diligence in looking for the true data, not online, not social media post things, but the true data. We know that the argument about the vaccines, again, right now the only thing we're using is Moderna and Pfizer, so I'm speaking about that. But we know that that argument about safety is a diminishing argument. We know that we have continually had data collection, and most recently this week we've had data coming about those vaccines showing that even in pregnancy they're safe, and there is that added benefit of maternal antibodies getting transferred to baby as well. So really the safety argument continues to diminish on a daily basis. The other thing is what happens when you get COVID-19. I know that we're all worried about blood clots. We know that you have a higher risk. 20% of people with COVID-19 get blood clots. That's large blood clots in their legs, large blood clots in their lungs. It's not the 1 in a million that occurs from the vaccination, particularly when we're talking about the Johnson & Johnson that is available here in the United States. The other issue is new data has now come out saying that if you had COVID, your risk of mortality is increased in the 6 months following, and your risk of continual medical problems is increased in those 6 months following COVID-19. And that is due to the long hauler symptoms, and it's brain fog, and it's the trouble breathing. So the amount in problems that you can get from COVID-19 itself is much greater than any safety concerns right now with the available vaccines.
And I think if I can add, I think what people forget is with everything that you do in life, there's a risk-benefit ratio. Imagine if we said, if there's any car accident that could result in a death, we're going to ban all cars. Yeah. If there's any plane crashes anywhere, you will no longer be able to fly. Yeah. We don't do that because we want to be able to drive to work, fly to see mom, and there's a risk-benefit in everything that we do. Even Tylenol, an over-the-counter medication, could cause liver failure in a very small number of people. So everything that we do carries a risk. Even vaccines have small risks, and we just need to weigh the benefits versus the risks.
Yep, I think it's a benefit for risk. Even if you have cancer, again, this is a therapeutic chemotherapy, but we know that getting chemotherapy can also lead to risk of getting further cancers on down the line. So it is that risk versus benefit, and right now what we have seen is overwhelming benefit versus any risk from getting these vaccines. So.
Sheree wants to know, when do you think that the mRNA vaccines will get total FDA approval?
Good question.
That's an easy answer. If you've been paying attention to what I said, the moment that the clinical trials are finished, and you can say, basically put a bow on top of that box and say, we finished the clinical trial, here's the data, then the FDA is able to review the data. But the one thing that is important to understand is normally, outside of a pandemic, all they need to review is the data inside of the box, right, from the clinical trial. But right now, they're getting data from the community as well, because we're administering this vaccine outside of a clinical trial. So when they get approval for that vaccine, they're not going to be reviewing only clinical trial data, which is very helpful. Obviously, there's blood draws. There's all sorts of other things that we collect in the clinical trial that we do not collect when we administer this vaccine to the public. But the FDA will pay attention to all of it. The reason why I'm saying that is because of the AstraZeneca vaccine that we did the study here. Everybody's asked me, why have we not gotten approval for that vaccine? Because it was rolled out in the world. And so the FDA needs to review the data we have from the clinical trial that we did right here at KU, in addition to all the data that has been collected around the world, and that takes a lot longer than reviewing the data that Moderna or Pfizer submitted that was just clinical trial data.
I think they are listening. I think that what the question is a clinical trial always 2 years?
Sometimes it's 1 year, sometimes it's 2 years. And that's what I meant with, and there are variations in that even if it's a 2-year trial, it might take them 3 years, because if they have to review worldwide data, that might take longer to figure that out and understand what is the true risk benefit of getting this vaccine if you have data that's coming in from all over the world. So even if the clinical trial is done in 2 years, if there's thousands and thousands of documents coming in, it might just delay it a little bit longer.
Okay, one more question from this morning, and then we're going to roll through the others. And if we have time, we'll get to the rest of the questions. But Anne wants to know, how do people who don't have an ID get vaccinated? Like homeless people and undocumented.
Yeah. I think there's probably various ways. I couldn't tell you specifically, but we know that there have been a lot of county outreach clinics. We know that Truman has done very well in county outreach if we're talking about specifically in the Kansas City community. But otherwise, I think the place to start then is the county health departments for that, or some of these other places that do have those come one, come all outreach clinics, such as we know Truman has had. We know that at one point there was a vaccine clinic at Arrowhead. I don't know what they would do. I think a lot of places do need ID, but that's a very good question. I would start with the county health departments. And, maybe they have some arrangements with the shelters as well and these other community outreach places so that we can get everybody. Because we know places where there are congregate livings, where there are shelters, things of that nature, those populations are extremely vulnerable to the disease.
It's my understanding you guys have the mayor here Monday.
Okay.
That might be a quick question.
Actually, it's Congressman Cleaver.
Congressman Cleaver. Somebody
He would be
that might
a
able to
very good
answer
expert at that,
Yeah.
Yeah, we will inquire. All right, let's go to our first question. So the multi-inflammatory syndrome cases in kids linked to COVID-19 surged in February after the holidays. Are we seeing more cases of MIS-C in children, and who is susceptible?
So basically, any child that is susceptible to COVID is susceptible to getting MIS-C. So MIS-C is not the immediate presentation once you get COVID. It takes a couple of weeks after you've had it for it to present. So you can imagine that if you have holidays, for example, Thanksgiving, Christmas, and people are getting exposed then those kids are going to be presenting with COVID 1 to 2 weeks later, right? And then 1 to 2 weeks later or a month out, you're going to see that MIS-C bump. So yes, you're right that after we have gatherings that put us at risk, we see one wave of the cases first, and then in pediatrics, we see the MIS-C wave afterwards.
Yeah, I know that was one of my major concerns before vaccination. And when the pandemic started and we first started finding out about those cases, that was my major concern for my daughter. The disease itself, yes, she would more than likely be fine, but she was still in that more higher risk age group, and so that was a real concern for me. Luckily, neither of my kids have had it, but that just goes to the side effects or the after effects of the disease itself. And I know for me, my largest concern was the blood clotting issue. If I did contract it as well. So again, we know that the vaccines for adults will help protect against those blood clots. Hopefully we will get this data for the pediatrics and be able to give it and show the benefit there as well.
One of my biggest concerns was the fatigue. I know there's a lot of really bad stuff that can happen, but I'm a pediatrician, so maybe I see the world through different eyes. I thought, I'll come here, you guys will take care of me and get me all better if it's something serious. But if I get hit with something like just extreme fatigue, like a lot of friends of mine have been hit who are infectious disease doctors, there's really not much we can do about that right now, and then you have to carry on through life doing that.
All right. When the Pfizer vaccine is EUA approved for children ages 12 to 15, will it be the current Pfizer vaccine or a different one?
It's the current vaccine, I believe. I think they kept the 30 microgram dose, but I have not seen that press release, I'll be honest, because I've been so busy focusing on the little ones. So I know what doses we're testing on the little ones right now, but I'm pretty certain that it's the same dose as the adults. But I can get back to you guys and send you a text and let you know so you can confirm that on Monday.
Okay, and you've sort of spoken to this a little bit, but what is the difference between vaccines for children and the vaccines for adults? You talked about the dosage is different, but will children need 2 shots?
Well, adults need 2 shots too. We do what we call priming and then boosting, and for now, we're going to continue to require 2 doses of children. The Johnson & Johnson product is the only one, as you know, that currently requires 1 dose only. But I can tell you that I've seen the protocols for the Johnson & Johnson pediatric trial, and they were looking at trying 2 doses as well.
Yeah.
And more importantly than how many doses do you need to be protected, how many doses might you need moving forward?
Yeah.
We are pretty certain that we're going to be needing to combine products in the future, meaning as variants come out and different manufacturers start to test new vaccines against the variants, we're probably going to need to get a booster against the variant. So it doesn't mean a booster with the same vaccine, but just like we do with influenza, where we tweak the influenza vaccine every year to adjust it for the strains that are circulating, we may need to get new vaccines against mutant strains and get boosted as those continue to arise.
And so also, for example, there are studies that have looked at in recent publications, some peer-reviewed, some not, that show you do get protection from that first dose of Pfizer vaccine. But the aim of the study was to look at the protection you mount. The aim of that study was not to say you are fully protected, because we still have the best data saying you have full and optimal protection after that second dose because of what you talked about, the prime, and then the boost of that specific immune response as well.
The FDA paused the J&J vaccine because of blood clots found in 6 younger women. How common is CVST among females in the general population ages 18 to 48?
Yeah, well, we were able to talk with one of our expert neurologists, Dr. Colleen Lechtenberg. We also had Dr. Alt, who was here last week, showing this graphic about what is the rate of CVST in people. And in the general population, it's 3 to 15 per 1 million. That is in the course of a year. In pregnancy, you can see there in the middle, it's 10 to 12 per 100,000 deliveries as well. In patients who are on certain medications, including oral contraceptive pills, 2.7 to 40 in 100,000 people. Again, pregnancy, oral contraceptive pill, you're probably looking at that same age range for the most part in that women, 18 to 48. That's probably going to be a majority of those people. So those are what the baseline characteristics are and the baseline rates.
And the general population risk, I can tell you that it tends to be also younger females that get affected the most. Males can have it too, and you can have an outlier, somebody older than 50, but overall the biggest risk tends to be younger women because of the mechanism by which this happens. If you think about it, in the risk that we see there, females tend to have a very robust immune system, and the stronger, healthier you are younger, the more active that immune system is. The mechanism of action, some of these adverse events, is actually immune mediated. So it makes sense that we are seeing this in females ages 18 to 48, 50, which carry the highest risk.
Yeah, you're exactly right. Actually, females, just as you said, 3 times more likely than males in general as well. So,
and we said that also of anaphylaxis.
Yeah.
More females were having anaphylaxis than males for the same reason. So this is consistent with what we know.
Is there data showing why breakthrough infections happen with the COVID-19 vaccines? Does it mean a person's immune system rejected the vaccine?
No, it doesn't mean that it rejected it. It means, for example, when we do the clinical trials and we give you data saying Pfizer is 95% effective, for example, it means that if you get the Pfizer vaccine, you are 95% likelihood of protection. It's an individual-based risk. But remember, the clinical trials were done with a very specific group of people, healthy adults. When we are screening for patients that are able to participate in the trial, we excluded people with immunocompromising conditions, with cancer, because this is, again, a study. But then when the vaccine gets rolled out under EUA, that vaccine may be administered to older people with waning immune systems, to people that have cancer, because we believe they are safe. But we did give the warning, they may not mount a robust enough immune response. So we are allowing them to get it, hoping they will respond, but it doesn't mean that they will. And so breakthrough infections can happen in people that didn't mount a robust immune response because their immune system is likely weaker than that of an average adult.
Yeah, and I think let's keep things in context as well. We understand that there was that original SARS. That infection died out. Well, that was a completely different infection dynamic where you really weren't contagious until about 5 to 7 days into your illness. This is completely different. The other thing is we know that there are common cough and cold coronaviruses out there that probably jumped species several hundred years ago, and they are continuing to be with us. So we have to keep that into context. And the other part about that is those common cough and cold coronaviruses, we know you can be reinfected with soon after, whether that's 3, 6, 9 months, a year after, with the same exact virus. But what we believe is that also when you are infected with those, your spectrum of disease, your symptoms are much less. So what these vaccines do is give you that immune response so that your spectrum of disease is much less even in those breakthrough infections, and you have that immunity there that is already built up to help act quickly. And we also believe, no significant published studies right now, but we also believe that because you have that specific immune response by the vaccines, you will then have less risk of those long haul symptoms, of those blood clotting phenomenon. So, a breakthrough infection is not unheard of and it's not unexpected, but what is important is that your chance of getting those severe symptoms, those hospitalizations and death, are even less with the vaccine, even if you have that breakthrough infection.
Yeah, so the easy way that I try to explain this to my friends and neighbors, for example, is if you get the COVID vaccine and you're more or less healthy, I'm not saying 100%, the likelihood of you landing in the hospital or dying from COVID is pretty much down to zero.
Almost, yeah.
But if you have an immunocompromising condition, you have cancer, maybe your immune system's not going to respond that well, I would still get the vaccine because there's no safety concerns of you getting it. Let's just be clear. No safety reasons why you shouldn't get it. But will it protect you the same way as it would protect me? Probably not. And that's where those breakthrough infections may come, but it's still worth getting the vaccine if you think about it again from a risk-benefit perspective.
Yeah.
All right. What about reports that both COVID-19 and the vaccine cause a change in menstrual bleeding? Is that true?
Yeah, I was able to talk with Dr. Carrie Weinecke, one of our OB-GYN experts here, who has been on the show before, just asking about that. So in general, we know that women can have changes in menstrual bleeding from all types of things, infection, stress, whatnot. There have been anecdotal stories about changes in menstruation. She noted one in particular that said there was a second menses in the month, but after, the next month it was totally normal. So there are anecdotal stories. I'm sure they are being looked at. There's no specific published stories or peer-reviewed things. But just as the important thing about long haulers who have gotten the vaccine say they are feeling better, these are all anecdotal. They are in the media. And we are hoping for actual peer-reviewed published data to really support and validate any of those findings as well. So anecdotal stories are out there, but we don't know what the preponderance is and what is the true etiology of all these changes.
And I think more importantly, is it clinically significant?
Right.
Does it matter? We don't think so. So
Right.
It's all right. If it happens, it happens, but it's not going to affect your health in any way.
Correct.
Will mRNA vaccines be used for flu shots going forward? And will it make them more effective?
I sure hope so, but of course right now we're kind of busy working on the COVID one, so eventually once all this dies down, I'm pretty certain that messenger RNA technology is going to be the way to deal with, I'm sorry to say this out loud, all the pandemics that are going to continue to happen to us, because we did see something with this pandemic is that we were able to respond to it very quickly.
Yeah.
That the virus was first identified December of 1999. By January, 2 weeks later, we had the genome fully published, available online for all researchers to work on it everywhere around the world. By July, we were enrolling our first participant in a clinical trial 6 months later. By December, we were getting vaccinated, you on air. So 1 year from the moment of discovering a virus to getting a vaccine, that's only thanks to messenger RNA technology and the adenovirus vector technology. So I do think we're going to move in that direction. But remember, this vaccine was very quick to come to the market because we have so much support from all the governments that banded together to push it forward because it's expensive to do this. All the other vaccines are going to have to go through the natural process, which is much more lengthy.
Yeah, and we'll say December 2019. But I would also like to point out we have been very lucky with this SARS-CoV-2 in the fact that the spike protein has been able to induce that immune response with B cells and T cells. We know that there have been other vaccines that have been in the works for different platforms of vaccines for things like HIV, RSV, CMV, EBV, all these viruses. But hopefully moving forward, there are currently a lot of plans to look at and develop mRNA vaccines for a number of different viruses, such as Zika, which we have all heard about. Other things like dengue and chikungunya, which is another virus that causes extreme body aches and pains and causes a lot of morbidity around the world. So we are working on those, but I think we have been extremely lucky in the fact that a lot of people were focusing on the spike protein, and the spike protein right now has shown to be a very good target for the immune system.
The messenger RNA vaccine had never been used before for vaccines in reality. The COVID vaccine is the first one, but the adenovirus vector vaccines have been used in the past to create an Ebola vaccine that is actually FDA approved, meaning they finished the clinical trials, it got real approval.
Yeah.
So at least we know that one of these platforms has been used for other vaccines.
I think, have they been using it in the recent outbreak as well?
Yes, so the
Getting
Ebola
the-
vaccine,
yeah.
the only one that's FDA approved uses the adenovirus vector.
Both my husband and I have been vaccinated, but one of us has autoimmune conditions. Is it safe for our younger kids to go back to school, or should they wait until a vaccine is approved for them?
So I think these are two separate questions. One is you have autoimmune conditions. The other one is can your kids go back to school? I think the can your kids go back to school is sort of a personal question, meaning how much risk, again, are you willing to take? I used to put my daughter in a flight when she was 5 years old to go see her father. I know a lot of people that wouldn't do that. Am I wrong? Are they wrong? Not really. It's a personal decision. So do you feel comfortable sending your children back to school when we know that there's not widely available vaccines for children yet? I do. My daughter, actually, our daughters go to the same school. They've been going to school since the beginning of the school year. I feel comfortable doing it. We both have been helping the school get back to normal and giving them advice about what to do it safely. So I feel very comfortable doing that. But I have a lot of friends that have not felt comfortable sending their kids back, and I respect that decision because, again, the risk is not zero, but we weigh the risk of, do I want my child to stay home or send them? So now the autoimmune issue with the parents, I don't think that should have any say as to whether the kids can go back other than could the kids bring back
Yes.
COVID and give
Yeah.
it to you.
Yeah.
But not that it changes your kid's risk of getting COVID.
Yeah, and a recent study certainly shows that with the variants, particularly the UK variant, there does seem to be a higher attack rate within the home. But I would really advise you to talk to your medical team, understand what are your risks. First of all, what is the condition? What, if any, medications are you taking that would also reduce your immune system? Get the vaccines, but discuss with your medical team about what the risks are for that.
And if I may add, I don't know if you've seen the same thing or not, but kids are awesome at wearing masks.
They are.
Even when my daughter has friends over to come for a play date, they're wearing masks all the time. All the time. I don't have to remind them. They do it on their own. I see them when we pick them up from school. They keep their mask on the car. I mean, kids are much easier than adults, I think.
Oh,
So
100%.
overall, when schools reopen, they have done, I think, a very good job of maintaining the kids safe. So I think the risk of the kids bringing it back to your house is low. But again, we can never say zero.
Yeah.
Can doctors speak to the variants in the metro area counties? Do vaccines work against them? Do they cause more serious illness? And Kathy writes this morning, she wants to know if you are aware of what's happening in Brazil, the increase of young children getting COVID and having serious illness. She wants to know if that's happening here.
So first, the metro area, then Brazil.
Yeah, so I'll tackle the metro area. So there is some updated numbers at the CDC website. It's a little behind, but as of the end of last month, there was a predominance of the B117. It was actually 46% in the state of Kansas. The numbers for Missouri were not too much different. The Brazilian variant, the P1, was 1.2%. The California variant, which was B1427 or B1429, was comprising about 8% or 9% of the total variants viruses identified in the state of Kansas, and then the New York variant was about 1.5%. And again, those numbers are not too much change between Kansas and Missouri, but to point that out, there is a large percentage, almost 10% of the California variant, and also a significant proportion, 46, almost 50% of the UK variant. The other issue is, do they work against them? The best lab data that we have and real-world data is yes, the vaccines do have efficacy against them. There was something almost recently published with, I believe it was the Johnson & Johnson or the AstraZeneca, that also showed that it does have efficacy, significant efficacy in protecting against severe disease and death for the variants, the UK and the South African variant as well. And we know that in the laboratory studies, Moderna and Pfizer also continue to have efficacy. Do they cause more serious illness? Initially, there was that big push that, yes, the UK variant has more severe disease. There was a recent Lancet publication when it compared people who had the other previous strains or variants or normal wild-type variants versus that UK variant, and it actually showed there was no change in morbidity or mortality between those two. So right now, the current thinking is it does not cause more serious illness in general.
So in general, to answer the Brazil question, what we pay attention to with variants, to make it simple, is three things. Can it make you sicker? So is there a mutation that the original virus had that made it make you sicker? Number two, is it easier to transmit? Number three, can it avoid immune recognition? And I call it the invisibility superpower. What I mean by that is, if you were vaccinated, you have antibodies. If I was infected naturally, I have antibodies. If there's a way that this virus wants to stay in, planet Earth because of evolution, it needs to figure out a way to infect us. You from vaccination, me from wild-type disease, because it wants to stay in planet Earth. So as it continues to infect other people, if it has a mutation that allows us to infect us in spite of us having immunity against it, that's the invisibility superpower, meaning it can get in visibility, go through the immune system undetected, and infect you again. So those are the three things we look for in the mutation. What's going on in Brazil is, in short, Brazil had a first wave of infections that was really serious, and about 75 to 80% of the population got infected naturally. Then the Brazilian variant came. And unfortunately, we were paying attention thinking, well, look, Brazil is going to reach herd immunity. This second wave was a mutant that had the invisibility superpower, and people got infected again. So that's one problem. Second problem is they also have this mutation, the Brazilian mutant, also has the capacity to bind better. When the virus gets into a human, it can stick better to the receptors and cause infection. So it's more likely to result in infection. So that's why we are seeing increased number of children land in the hospital, because the virus has learned how to stick better and result in disease in that country due to the mutants.
Right, a couple more questions here. I had COVID-19 in January, and I received 1 dose of the Pfizer vaccine. Since I did not get the second shot, what percentage am I protected, and should I go get the second shot?
So did you get COVID in January and the Pfizer vaccine after January or before? I'm going to answer it both ways since I don't think we have the answer. If you had COVID first and then got your Pfizer vaccine, in the United States, we're currently recommending that you get 2 doses. So you should go ahead and get it at least 21 days after your first dose. If you had your first dose of Pfizer and then got COVID, we would still recommend that you get your second dose, but I would then say that you get your second dose once you're completely recovered from your COVID illness.
Yeah, I think the best data we have is that you're probably about in that 60 to 70% protected, again, from that severe illness, from death, compared to 95% or more if you get that second vaccine. But the other question to go along with that is, how long does that immunity last with just that one vaccine dose and the natural infection? It's probably not going to be as great as if you get that second dose, really to further boost that specific immune response with those B cells and T cells. So go ahead and get that second dose.
Now, in other countries, they are using your first illness of natural COVID as your priming.
Yep.
And the first dose of your vaccine as your boosting. France, for example, has said that if you have had COVID, you only need 1 dose of the shot. That's not what we're recommending in the U.S., but maybe that's why this person asked that question. So it is true what you heard is not a rumor that in some countries 1 dose is enough if you've had COVID, but in the U.S. we still recommend 2.
All right, what about an outdoor gathering of 25 people who are all vaccinated? Are we safe?
I'm going to guess we're going to answer this different, so I'll let you go first.
I don't know. Again, it goes to personal risk versus benefit. First of all 25 people may be vaccinated, but what about all 25 people in their households? Is their household fully vaccinated? So that's the other question to answer. I think, outdoors is still better, but you are still getting a lot of people together who may, there's probably a good chance that one of those people may still have it. I think it's still a little bit risky. It's still not recommended in the guidance. I would put that in the more moderate, not large amount of gathering, and certainly not small. And so that is still not recommended. Again, outdoors is better. I think your risk is higher. And then, kind of that's where we're at, is just a benefit versus risk. It still kind of really wouldn't be allowable under the CDC guidance.
So technically speaking, if you tell me it's a soccer game, there's 25 people out there,
Right.
You're all outdoors, I would still recommend that you wear masks because of what you just said. If you told me it's a private party what's the point right now, really, of getting 25 together, people, in the same place for those reasons? I think if we really want to get rid of this pandemic, even though they're all vaccinated, again, I would probably limit it to less people, continue to do at least the 6 feet apart if you're outdoors. And I do think, though, however, that being vaccinated comes with some privileges. So if you are vaccinated, and I have done this, I have gathered in my backyard with my friends, and we're sitting outside without masks, talking to each other, 4 or 5 of my closest friends, we're all vaccinated. I think that is good also for mental health. But would I go as far out as doing 25? Absolutely not at this moment.
Yeah, I mean, can you maintain that distance? I think that's a good point there.
One last question for Dr. Pahud, and then we're out of questions. We're not out of questions, but we're out of time, rather. Kathy wants to know if you follow what's happening with COVID all over the world involving children, because she said she's impressed by what she heard about Brazil today. She's not heard that on the news, and she's not heard it explained that way. So she's just curious about, I think, how you're spending your time and what you're doing.
Yeah, so I spend a lot of time reading up on everything that's happening around the world, not just in children, but for the vaccine throughout, because we are involved in adult and in pediatric clinical trials. That's part of my job, to be a vaccine advocate. And also, my first job, I think, my first hat is always vaccine safety. So I try to make sure that I'm reading up on all the data that's coming in from the European Union about AstraZeneca, in the United States about Johnson & Johnson. There's going to be a meeting today with the Advisory Committee of Immunization Practices. I'm going to be listening to that as well. I don't know how, because I also need to take my daughter to get her Moderna vaccine clinical trial visit. So I'll be driving her there while I'm listening to this data. But if we want to be able to continue to inform our patients, we need to stay abreast. So just like you are, we're just reading everything that we possibly can.
All right.
All right. Well, thank you. Please send us more questions. I'm sure there will be on Monday. And on Monday, we have Missouri Congressman Emanuel Cleaver. He'll be here in studio and talking about how COVID has impacted Missouri. Please bring your questions or think of them this weekend. Any final thoughts?
Yes, I think if you want to do anything to help to finish this pandemic, just get a shot, any shot, because if you get a shot, you decrease the chances of mutant viruses arising. So that's the most important thing we can all do. And wear masks.
That's our way out of this, is vaccination, helping reduce replication in your individual body, helping reduce spread in your community, and helping reduce the chance of any other variants arising as well.
And one last thing is, if you want to participate in the pediatric clinical trials, go to the childrensmercy.org website and search vaccine research, and you'll be able to sign up your child online. It doesn't mean that we may call you right away. We have over 5,000 kids signed up, and then only 100 or so slots, but still sign up because you might still be able to be eligible for the study.
All right. Well, thank you all, and again, keep your questions coming. I know we missed our Captain Kirk here. This was more like
You did great.
Han Solo flying the Millennium Falcon instead, but we tried to take you through it. We'll be happy to answer any other questions. Please stay safe this weekend.